Yes, I'm Bob Fisher. I'm very grateful to be speaking at your exciting symposium. I'm sorry that I could not travel to be there in person, but I am giving this talk live. In terms of conflicts of interest, I have none with this talk. I have no financial connection with any ultrasound company or neurostimulation company. I'm not being paid for this talk by my choice. And I am a volunteer for the Focused Ultrasound Foundation in the United States. So why do we need focused ultrasound for epilepsy? Over the centuries, epilepsy has been treated by many different modalities, probably starting with trephining, opening the skull to let out demons. And I must say that that was particularly effective because this particular skull has not had a seizure for over 2,000 years. Now, it then devolved to prayer and incantation to cast out demons, and then subsequently a large list of anti-seizure medications. Then came more modern surgery with mesial temporal lobectomy and subsequently neurostimulation. So I will say a few words about each of these in relation to focused ultrasound at the end. Some people mistakenly consider epilepsy to be a solved problem because we have so many medicines and surgery, but it is not. Epilepsy affects 1% of the world, a condition of spontaneously recurrent unprovoked seizures, 1 out of 100 people. And uh, medications work in about 2/3 of those, but the number who remain uncontrolled is larger still than all brain tumors, all multiple sclerosis, all muscular dystrophy, all amyotrophic lateral sclerosis. So it's far from a solved problem. Now, we do have 27 approved anti-seizure drugs in the United States, but as I mentioned, they only control seizures adequately in about 2/3 of patients. They have many side effects, including birth defects. They have drug interactions that require regular blood tests, and patients taking the medications properly and on schedule happens a disappointing fraction of time. Plus, if you have to take them for your whole life, they can be quite expensive. So we do have surgical procedures. You see an open anterior mesial temporal lobectomy, and the image on the right side of my screen shows the uh, lesion that it creates, maybe on the left side of your screen. In the United States, increasingly, we're using lasers to do surgery. You can see the insertion of the laser from the posterior aspect into the hippocampus. It can reach all the way forward to amygdala, and then a controlled heat lesion is produced. It spares the neocortex, and the patient can usually go home the day after surgery. It has fewer neuropsychological subsequent problems than does open surgery. It's not quite as effective, but almost in reducing seizures. There are problems with surgery, just like there are problems with medicines. We can only remove or laser ablate one seizure focus. We can't take many out across the brain. We need to know where that seizure focus is. Localizing a focus has its own risks, as we see on the slide with a subdural stimulating recording grid to map seizures in relation to eloquent cortex. The focus must be safe to resect, and the surgery is invasive with risks. You don't go home the next day after surgery like this. And even with all of this, only half remain seizure-free. Neuromodulation, which often is called neurostimulation, has probably revolutionized is too strong a word, but almost revolutionized our treatments for patients. And it is very rare now when we say there's nothing that we can do, because usually we can do some type of neurostimulation. In the United States, we have three types: stimulation of the left vagus nerve in the neck, responsive neurostimulation, which allows putting one or two contacts over or in seizure foci directly on cortex, sensing the seizure and then giving a stimulus to counteract it. I think it also has a long-term neuromodulatory role as well as its seizure shortening role. And then deep brain stimulation of thalamus, a pacemaker way station that can particularly influence brain networks all over the brain and can palliate seizures. This shows a comparison in the blinded phase of the multicenter clinical trials and then long-term at 5 years of each of the three different types of neuromodulation. The effects are not curative, but about 15 to 20% of people will have elimination of seizures for at least 6 months at a time. And it may enable reduction of medications, fewer injuries, and so on. So it is beneficial, although not typically a cure. This tabulation, which I pulled together from the National Association of Epilepsy Centers in the United States, showed that in 2022, there were more neuromodulation procedures performed, not counting battery changes, than there were ablative surgeries in the US. My guess would be that this gap would be even greater if we did that survey in 2024. So there are these problems with medicines. The problem with surgery is it's basically invasive. Neuromodulation, as we do it, is minimally invasive, but still invasive. Can we make it non-invasive? I will just mention that there are a couple of technologies that I think potentially would be competitors to focused ultrasound. One of them is transcranial magnetic stimulation, which I show here on myself. I don't have seizures, but I didn't want any patient privacy problems in the photo. So it shows a magnetic coil held next to the head with a beam guided by neuronavigation and high-density dipole localizing EEG being run simultaneously. So this is transcranial magnetic stimulation, which has shown some efficacy in several studies for reducing seizures. No big controlled randomized trial yet, though. Lately, I've been working with transcranial direct current stimulation, as have many other people. You can see in the summary of clinical trials, only including those that had some sham control group for stimulation, that the orange bars are much higher than the blue bars. The blue bars are sham stimulation, which is just on for a minute. The orange bars are 20 or 30 minutes of transcranial direct current stimulation, often given for several different sessions. And higher is better, so you can see a greater degree of seizure reduction. At Stanford, we have taken that inpatient into our neurological intensive care unit, where patients have focal status epilepticus that does not stop, with multiple anticonvulsants or anesthetics such as propofol. And we've found so far anecdotally some success with transcranial direct current stimulation in this group. These charts are on 4 patients, our first 4 patients, which we published as a small case series. We've now done 17. And you can see the dots are spikes and the lines are seizure counts per hour. And you can see that after transcranial direct current stimulations, they sometimes go down, although not always. This patient wasn't helped much. So these are non-invasive methods of delivering neuromodulation, just as focused ultrasound is non-invasive. The problems with electrical and magnetic stimulation are that by the laws of physics, they activate large regions of brain and are difficult to focus. So you end up stimulating a number of areas that you might not want to stimulate. So what would be the ideal, in my opinion, neuromodulation for epilepsy? It would be safe, it would be effective against seizures, it would be non-invasive, it would be convenient to deliver, it wouldn't have any stigma. Kids wouldn't say, what's that funny thing on your head? It can penetrate both deep and superficial into brain because you will have seizure foci any place there's gray matter in the brain. You can be focused on a specific target and it should be easily available at medical centers. I'll watch the rest of this symposium with some interest to see whether the ideal on this slide is met by focused ultrasound. And then in my last slide, I just wanted to mention that we are in the United States starting another pilot trial, not the first, you'll hear about the first, but one of the first in the US on the safety of modulatory focused ultrasound targeted for 6 patients. It will be at 3 centers. I've listed them: Stanford, Harvard with Ellen Bubrick, who's been a pioneer in this area, and University of Virginia with Nathan Fountain. The study has been approved by the FDA. It's in adults that have at least 4 seizures a month and up to 2 seizure foci, which probably would be bitemporal seizures in most cases. We will deliver 2 sessions per week for 3 weeks, 6 sessions total for the parameters that you see below. And we will look at EEG, CT scan, MRI, and neuropsychological studies. The outcome is to be safety and a preliminary look at efficacy. We hope that this study will start in the next few months. So there is a landscape of existing therapy, some definitive open surgery or laser surgery, although laser is not available in all countries. And there are several possible neurostimulation modalities, 3 of them documented by large trial, but all 3 of those being minimally invasive. And then hopefully on the horizon, some non-invasive magnetic or electrical stimulation therapies. But none of them has all of the ideal characteristics that I mentioned. And I am hopeful that that focused ultrasound, modulatory focused ultrasound, will meet a very great need for uncontrolled epilepsy in a large number of patients around the world. Thank you very much.
Thank you, ladies and gentlemen. Please give a round of applause to thank Dr. Fisher for his wonderful presentation. Thank you.
Thank you.